So today's topic is neoplasm. Neoplasm is abnormal mass of tissue, the growth of which exists and it is uncoordinated rate of normal tissue and persists in same excessive manner even after cessation of a stimuli. Neoplasm is a progressive, persistent, it is purposeless, perverted, proliferative mass of tissue and pervasive. So it is a progressive growth, it is persistent and purposeless, and this is perverted. It is a proliferative mass of tissue. It can be malignant, it can be benign. There is a difference between benign and malignant. Benign is well differentiated. Malignant is lack of differentiation. Benign structure are typical of tissue or cell origin. Malignant atypical structure with anaplasia. Benign is a smooth, slow, progressive rate of growth. Malignant, rapid growth. Benign, well localized and encapsulated. Malignant is not localized and is not capsulated. Benign growth is normal mitotic figure, have a normal mitotic figure. Malignant is abnormal mitotic activity. Benign do not infiltrate surrounding normal tissue. Instead of that, malignant is infiltrate the normal surrounding tissue. In benign, you know all, it is not metastasis. Malignant is metastasis through lymphatic or through blood, and also local infiltration. So this benign is curable. Malignant may not be completely curable. In benign growth, treatment is simple, and in malignant, treatment is complex and complicated. Multidisciplinary team and multidisciplinary treatment is required. It may require surgery. It may require hormonal therapy, chemotherapy, or radiotherapy. And benign is only we can exercise simply. We can do surgery. In benign, no recurrence, and all you know, malignant tumor is a recurrence. Can occur. Malignant, you know what is meaning of malignancy? Can be carcinoma, and it may be sarcoma. But meaning of carcinoma is a crab-like, and meaning of sarc is the flesh. So there are two types of malignant growth. It may be sarcoma, and the second one is a carcinoma. Sarcoma is arising from mesenchymal cell. Carcinoma arising from epithelial cell derived from 3 germ layers. Sar means flesh and oma means tumor. So it is a flesh tumor. Carc, I have already told you, meaning crab-like. Sarcoma is smooth, curved, or hard swelling. Carcinoma is hard, proliferative, everted edge. Sarcoma, warm and vascular with dilated vein over the surface. Sarcoma is spread mainly through blood, commonly to lung, liver. For example, liposarcoma, fibrosarcoma. Carcinoma is spread through lymphatic as well as blood, but mostly it is spread through the. It is specificity is the is spread with the lymphatic. For example, squamous cell carcinoma, renal cell carcinoma, adenocarcinoma. Neoplasm, which are only locally malignant, are there are no blood spread, no lymph node spread. Examples are marginal ulcer, rodent ulcer, verrucous carcinoma, adenocarcinoma. They are locally malignant. They don't spread with the blood or lymph node. They are only locally malignant. Neoplasm, which are locoregional, which locoregional means they spread locally as well as with the lymphatics. So spread only though to regional lymph node. Observe examples are squamous cell carcinoma and papillary carcinoma, thyroid. You know, very important. This is the very important topic, and these are very important. Like papillary carcinoma occur in a 20% of patients. It is loco-regionally malignant. It is spread with the lymph node, so it can be curable. It can be cured. We can cure it with the we can cure with the wide excision, or we can do the thyroidectomy. If it is spread with the lymph node, so we can excise lymph node also. So we can do MRND or RND, modified radical neck dissection or radical neck dissection. Now come on the neoplasm, which are systemic, spread through blood and often also to the lymph node. Examples are melanoma and carcinoma breast. Carcinoma breast is the systemic disease. We can say it is spread with the local locoregional and also to the distance metastasis with the blood. So it can spread to bone, it can spread to brain, spread to lung, and also to the liver. Component of neoplasm is the parenchyma. It contains proliferative neoplastic cell and stroma. It contains supportive connective tissue and blood vessels. Now come on the features of anaplasia. Features of anaplasia are lack of cellular differentiation. Second, pleomorphism, variation in size and shape. Third, hyperchromatism, dark staining nuclei. Fourth, anisonucleosis. And fifth is abnormal mitotic activity. So these are all features of anaplasia. Now come on the features of malignant tissue. Malignant tissue is the altered differentiation, anaplasia, rapid rate of growth. In malignant tissue, local invasive, it may be locally, lymphatic, vascular, and perineural invasions. Metastasis occurs, not capsulated. Benign is the capsulated. Increased vascularity is the feature, which is also a feature of malignant tissue. And microscopic changes are necrosis, numerous atypical mitotic activity, nuclear charge like pleuron change like pleomorphism, enlargement, hyperchromatism, clumping of chromatin, enlargement, and multiplication of nuclei. So these are all features of malignant tissue. Now come on the dysplasia. It means distorted growth. There is loss of uniformity of the cell with pleomorphism and hyperchromatism, as well as loss in their architectural orientation. Carcinoma in situ. You have heard many times carcinoma in situ. Carcinoma in situ is there. Here, dysplasia involve entire thickness epithelium and in pre-invasive basement member normal impact in carcinoma in situ. It is now come under etiological factor, which very important. There are many etiological factors for the carcinoma, but we can say neoplasm, but most important are age. First, age, it is more common in elderly, but it is variable. It can be occur in the younger age group also. Second, hereditary, like familial polyposis of colon. Second, Amiens syndrome, multiple endocrine neoplasm syndrome, neoplastic syndrome. Third, neurofibromatosis. Fourth, Van Hippel Lemdu syndrome. These are all hereditary. Next is a genetic, like xeroderma pigmentosa, ataxia, telangiectasia, Fanconi anemia, and blood syndrome. It can be acquired causes like chronic atrophic gastritis converted into the stomach. Solar keratosis causes skin cancer. Leukoplakia of oral cavity causes buccal mucosa cancer, squamous cell carcinoma of buccal mucosa. Ulcerative colitis causes CA colon, carcinoma of the colon. There are multiple chemical carcinogen, which also causes carcinoma, like alkylating agent, like hydrocarbon, smoking related with various diseases of various organ, like lung cancer, aerodigestive system cancer, and also carcinoma bladder. Asbestosis is also related to the lung cancer. Alcohol related to liver cancer. Amides and erodi, carcinoma urinary bladder. Alpha toxin B1, ericolin, collagenase, and tannins present in betel nut, which is responsible for carcinoma of oral cancer, carcinoma buccal mucosa, tongue, and nitrosamine, vinyl chlorides, and insecticide. These are all related with the various cancer. Now come on the geographical variation. Like in Japan, carcinoma stomach is very common. In China and France, carcinoma esophagus. In Hong Kong, nasopharyngeal carcinoma. In India, carcinoma oral cavity due to use of tobacco and betel nut, which are responsible for the carcinoma tongue, carcinoma buccal mucosa, and also in India, carcinoma gallbladder. In New Zealand, a small bowel tumor is very common. There are various radiation carcinogen, ultraviolet rays, and ionization radiation, they are also related with the various cancer. Also, microbial carcinogens, they are also responsible for the carcinoma of various organs, like human papilloma virus, they causes carcinoma cervix. Epstein-Barr virus, it causes Burkitt lymphoma, naropharyngeal carcinoma. Hepatitis B virus is responsible for the liver cancer. Human T-cell lymphoma, virus type A, and Helicobacter pylori can cause carcinoma of the stomach and also started with lymphoma. Now come on the tumor suppressor gene P53. It plays very important role in prevention of cancer. Its function is prevention of replication of damaged DNA. If damaged DNA replicates and there is high chances of abnormal mitotic activity and cancer transforming tissue. Loss or reduction of ability and function of P53 suppressor gene can lead into cancer. Common cancer associated with P53 gene loss are, one is the carcinoma of breast, very important. Second, colorectal carcinoma. Third, bone and for brain, retina, soft tissue, and related type of cancer. Now come on the very important, you can ask in the examination, what are the different mode of spread of malignant tumor? There are different modes. One is local spread into adjacent tissue, structure like soft tissue, vessels, and bone. Second, it will spread with the lymph node, lymphatic spread by permeation. Here, malignant cell proliferate through lymphatic vessels up to lymph node leaf. For example, carcinoma breast permeated into axillary lymph node. Second, by embolization. Here, cell gets dislodged from lymphatic tissue vessels and freely travel to spread into further level of lymph node. So, that is second type of lymphatic spread by embolization. First is by permeation. For example, carcinoma lymph node breast by embolization. Spread occurs from axillary node to supraclavicular lymph node. Retrograde lymphatic spread occurs once lymph vessels get blocked by lymphatic infiltration in carcinoma breast. Retrograde spread also occurs on the opposite breast, opposite axilla or mediastinum through dermal lymphatic, and retrograde spread in transit nodes nodule occur in spleen. Now come on there are different also carcinoma can spread with the blood, spread into distant organism like in the bone, brain, on the lung, and also to the liver. Carcinoma can also spread by the translumic spread can occur, like carcinoma stomach can spread into the ovary, and also by the seedling, for example, carcinoma lower lip spread into the upper lip. So these are all mode of spread of carcinoma. Now come on the grading of tumor. It's also very important. It signifies aggressiveness of tumor. It is based on differentiation of any tumor cell and mitotic activity. Border grading of squamous cell carcinoma based on keratin epithelial pulse. Grade 1, well differentiated, more than 75% epithelial pus. Grade 2, moderately differentiated, 50 to 75% epithelial. Grade 3, poorly differentiated, 25 to 50% epithelial pus, and grade 4, less than 25% epithelial pus. So, very important. It can be a carcinoma can be well differentiated, can be moderately differentiated, can be poorly differentiated. Now come on the special features of malignant cell. It is independent and autonomous nature without any control of need. So it is autonomous in nature without any control. Second feature of malignant cells is a normal telomic shortening is altered. Later, telomere gets shortened and cell division stops. It is altered in malignancy with infinite cell division. It reduces cellular apoptosis. Normal cell has capacity to die once its function is over, but not with the case of malignant cell. It is normal programmed death of cell. It is activated by tumor suppressor gene P53. Tumor has got capacity to create and construct blood supply, called as angiogenic capacity. Malignant cell invade through the basement membrane, through blood and through lymphatics. It is through secretion of a special enzyme increase interstitial pressure, capacity to have motility, release of collagen and protease integrins. Spread occur by proliferation and permeation as well as by embolization. I have already told you. Creation of instability and alteration of existing tissue function, not obeying normal tissue function of the dead particular size. So these are all features of malignant cell. Now come on the Gompertz design growth. Gompertz design growth, it is a rapid growth of tumor cells prior to its chemically detectable stage. Once it becomes chemically detectable, which needs third generation of cell division, 1 mm tumor is more than 10 to the power 9 cells. Its growth slow down later. This late slow growth is due to less oxygen to the tumor by competition between host cells and tumor cells and between tumor cells and cells themselves. Tumor maturation occurs as a different generation of division stabilizing the tumor further. Staging of tumor. It is very, very important. You know, this based on size of primary tumor, nodal spread, and blood spread. It is called TNM staging. It is very important, very common tumor nodal metastasis staging. TNM staging is more relevant grading in managing, predicting progress. Now come on the paraneoplastic syndrome. It is also very important, can be also in the practical as well as theory examination. You must know certain symptoms complex which are not specifically explained by tumor, but as a relevant upon problematic and life-threatening are called as a paraneoplastic syndrome. Incidence seen in 10% of the patients. So this is the paraneoplastic syndrome. I don't give in a detail about paraneoplastic syndrome. Now come on the investigations of neoplasm, it is very important. A patient of a growth or a neoplasm occur in the OPD or in the surgery department, you must know how investigations you do for the confirmation of the diagnosis of the neoplasm. First and very important is the biopsy. There are different type of biopsies. It may be like FNAC, incision biopsy, two-cut biopsy, excision biopsy, frozen section biopsy, CT guided biopsy, USG guided biopsy, and cystoscopic biopsy, colonoscopic biopsy, frozen section. These are all different type of biopsy we can do in a neoplasm of the patient. But important is the biopsy. Biopsy means life or tissue. Bio means life or tissue, and opsis means vision or by the microscopy. Vision or the microscopy. Opsis means vision to see or microscopy. Biopsy means life or tissue. Biopsy means the study of a tissue using microscopy or life by vision, or we can say vision for life to save the life. This is the meaning of biopsy. You must know. Type of biopsies, I have already told you. There are different type of biopsy like incision biopsy, excision biopsy, two-cut biopsy, pap smear, FNAC. FNAC very important. You have done frequently. Fine needle expression cytology. Frozen section set up in the OP. We do during operation. Punch biopsy, we also taken punch biopsy. Ultrasonographic biopsy, laparoscopic biopsy, CT guided biopsy, thoracoscopic biopsy, bronchoscopy also very important. Endoscopic biopsy like gastroscopy, colonoscopy, or through ERCP also we have done. Endoscopic retrograde cholangiography we have done for the diagnostic as well as for the therapeutic purpose, and we can take biopsy by the ERCP and cystoscopy. Like in bladder cancer, we take biopsy by the cystoscope. Proctoscopic biopsy for the colon cancer, we can do proctoscopy or we can colonoscopy and take biopsy. Open biopsy by the laparotomy, or by laparotomy we take biopsy from the peritoneum, from the we can take the biopsy from the peritoneum. And thoracotomy or craniotomy using Dennis brain cannula. We can take the craniotomy. We can do craniotomy and brain biopsy. Now come on the incisional biopsy. Incisional biopsy, it is taken from the edge of lesion as in ulcer, not from the center. We take as a because in the center there is a necrosis, so we can take a biopsy, incisional biopsy from the edge. Incisional biopsy is contraindicated in case of melanoma, where excision biopsy is preferred. In secondaries, in lymph node, FNAC is preferred. If it fails to give information, then we can take incision biopsy. Otherwise, FNAC is the sufficient investigations for the secondaries in lymph node. Note, secondary biopsy is taken from the center of the lesion only in post-radiation ulcer and syphilitic gumma because of radiation. There is no blood supply in the margin and proliferation in the center of lesion. Excision biopsy, it is a small lesion. In a small lesion, we take excision biopsy. For example, lymph node biopsy in case of lymphoma. Now come in the true cut biopsy. It is done using a specialized device using wherein gun with true cut is inserted into the surface of tissue or organ, and the gun is tilt to close the puncturing tip of needle to cage, then cut adequate tissue. It cannot be done to deeper tissue which are close to major vessels or structure, important structure like in the neck, in trachea or trachea and carotid. It is done in prostate, breast, and in surface tumor. So we can take true cut biopsy by of the breast and of the prostate. We are taking already. FNAC, we have frequently done FNAC. FNAC is a cytosurgical study of tumor cell to find out the disease and also to confirm where it is malignant or not. It is done in thyroid, breast, and lymph node, FNAC of the lymph node, and surface lesion. In follicular carcinoma of thyroid, we take FNAC. It is very useful as angioedema and capsular aneurysm are specific, cannot be detected. In lymph node, it is useful to detecting secondaries as well as tuberculosis. USA guided or CT guided FNAC are popular at present, especially where it is done from liver, lung, and kidney. From different organ or the structure, we can do CT guided or USG guided FNAC. It is absolutely contraindicated in testicular tumor because subtunica albuginea usually prevent tumor spread, and on its disruption by FNAC, spread can occur. So, FNAC is contraindicated in testicular tumor. Advantages of FNAC, it is very sensitive. It can be done in OPD basis. It is least invasion. It's safe. It's fast, cheaper, and anesthesia is not required in FNAC. So, FNAC is commonly done procedure in OPD, in surgical OPD, and it is very good. It's sensitive, least invasion, safe, fast, cheaper, and without anesthesia, it can be done. Tumor dissemination through breast is not present except in testicular tumor, where it is done. It is not done. Presently, DNA study of cell can detect very early malignancy. Disadvantage of FNAC is negative result cannot rule out malignancy. So, if a patient has a FNAC, negative FNAC, we have to do other mode of biopsy. Tissue study is not possible with FNAC. Further study not amenable with the FNAC. Now come on the frozen section. Frozen section biopsy, it is done in pathology setup existing to OT. It is done in the OT basically, and unfix the fresh tissues frozen using carbon dioxide in metal, and section are made and stained. It is technically difficult processing, and staining is poor quality and often difficult to get accurate results. So this is the disadvantage of frozen section biopsy. Advantage: quick and surgeon can decide the further step of procedure in same setting, like nodal clearance type of resection to be done. It is done in carcinoma breast or follicular carcinoma thyroid when FNAC. As during surgery, after resection of tumor, to look for an on-table clearance in margin and depth, and also lymph node for their positivity. These are important of frozen section. Next, investigations for the carcinoma for the neoplasm is the immunohistochemistry. It is the detection of specific antigen using an antibody. Antibody label says is due bind to antigen in section of tissue causing a specific color like brown and determine the pressure and distribution in tissue. It is safe, specific, and quick. To confirm, to find differentiation, to detect metastasis, to plan type of therapy. It is very important. Immunohistochemistry. To categorize leukemia or lymphoma, either of T cell or B cell type. It is to find out site of origin of metastatic tumor. That is by doing PSA in prostatic cancer or thyroglobulin in carcinoma thyroid. Detection of receptor molecule, that is estrogen receptor in carcinoma breast. ER positive has better prognosis. Presence of oncoprotein product CRB2 in breast cancer signifies poor prognosis. GIST, gastrointestinal stromal tumor, can be treated with imitinib if it shows CD117 expression. Endocrine tumor are assessed on K167 proliferative index. Next investigation is the tumor marker. Tumor marker are biochemical indicator of presence of tumor. They are not used for primary pathological diagnosis. They have prognostic value. Presence of tumor marker signify recurrence of residual. Other method or other investigations for the neoplasm are the electron microscopy, in situ hybridization, PCR, fluorescence in situ hybridization. Next is the management strategy for carcinoma. It is very important. If the patient has a carcinoma, what you will plan to plan for the management. So, plan of management strategy, we can say, first we diagnose and confirm by the biopsy. Second, evaluation of staging, metastatic workup. Third, our strategy will be approach for primary, like surgery or radiotherapy or chemotherapy. Approach for the secondary. Fifth strategy will be palliation in advanced stage, palliation of distressing symptoms. So this is the plan. Treatment of tumor: first is surgery, wide excision or radical excision. Second, radiotherapy, it is curative or palliative. third chemotherapy, fourth immunotherapy, and fifth is the gene therapy. These are all treatment of tumor. Now come on the malignancy which are curable like basal cell carcinoma, adenocarcinoma versus verrucous carcinoma, marginal ulcer, carcinoma colon, and papillary carcinoma of carrot. These are malignancy which are curable. Carcinoma which spread to lymph node like navel sarcoma, Ewing sarcoma, lymphosarcoma, Kaposi sarcoma, rhabdomyosarcoma, or angiosarcoma. These spread to the lymph node.